Hi all. Welcome to another session of E-Path to Success. So starting with this quote, that is work hard in silence, let your success be your noise. Let's begin. The topic of today is salivary gland tumor updates. Myself, Dr. Revati K, MDS, Department of Oral Pathology. Completed my MDS from Government Dental College, Kottayam. So salivary gland tumors, as we all know, it has got a wide spectrum of tumors where the differential diagnosis of one from the other is very difficult. So over the years, WHO has revised the classifications right from 1972 till 2017. The classifications have been changing with addition of many entities and even collapse of many other entities, renaming of some, and so and so. So here we'll be briefly discussing about some of the tumor entities which were added, some which were removed, and some of the other names which were changed. And for the postgraduate students, I think that this will be helpful. So the contents of the session would be the various WHO classifications right from 1972 till 2017. And then you have that 4th edition update, that is 2017 update, where which all entities have been added, and discussing about some of the entities which are new, like Secretory Carcinoma, then Cribriform Adenocarcinoma, which was grouped under polymorphous adenocarcinoma. Then coming to some other epithelial lesions like Sclerosing polycystic sialadenosis or intercalated ductal hyperplasia, and also some of the genetic molecular alterations that have been added into the new classification. So let's begin. So we all know salivary gland tumors have got a wide spectrum, and WHO from the earlier classifications have changed a lot into the new 2017 classifications. Right from 1972, we have just benign tumors or malignant tumors like adenomas or carcinomas, where the basic tumors have been classified. From that, over the years, 1991, some of the new entities were added. 2005, some others were added, some others were removed. And latest, that is the 2017 classification. How it is different from the 2005 classification is that the secretory carcinoma, that is an analog of mammary analog secretory carcinoma of the breast, was added into the salivary gland, but the term mammary analog was removed and secretory carcinoma alone was added. Then the terminology of low grade was removed from polymorphous adenocarcinoma. Then another variant, that is intraductal carcinomas, just like intraductal papillomas, intraductal carcinoma was also added, which was a malignant counterpart of ductal papillomas. Then, of course, the poorly differentiated carcinoma, like some of the large cell, small cell, or undifferentiated carcinomas were grouped as together into poorly differentiated carcinomas. And xyloblastoma was separated as a borderline tumor. And also some of the other epithelial lesions like sclerosing polycystic adenosis, nodular oncocytic hyperplasia, lymphoepithelial lesions, or intercalated ductal hyperplasia were added. And some of the other benign connective tissue tumors like lipoma or nodular fasciitis, which happens within the salivary gland tumors, were also added as a soft tissue lesion together with hemangioma. So these are some of the modifications that were made. So beginning with the major updates, that is secretory carcinoma, which was added when mammary analog was removed. And you have this particular gene alteration, that is ETV6 NTRK3 gene fusion, which is particularly specific diagnostic aid of secretory carcinoma. And secretory carcinoma was almost similar in differentiating it from actinic cell carcinoma. So some of the differentiating features will be discussed later, but ETV6 NTRK3 gene fusion, do not forget, that is one of the major gene fusion that is seen in secretory carcinoma. Okay. And as I said, low-grade term was removed and Cribriform adenocarcinoma was added under the polymorphous adenocarcinomas. And Cribriform adenocarcinoma, earlier it was termed as Cribriform adenocarcinoma of the tongue, CAT. But because majority of the sites were tongue, but so when other cases were reported, Cribriform adenocarcinoma were to be seen in buccal mucosa and other posterior pharynx, and all other areas. So the terminology of tongue was removed and just Cribriform Adenocarcinoma and salivary gland was added. So that is it. So starting with, this is we have already discussed. So starting directly with Secretory Carcinoma or MASC, mammary analog secretory carcinoma, which was almost similar to that of breast CA, and the particular chromosomal translocation seen in T12-15 and resulting in this gene fusion. So how is MASC different from actinic cell carcinoma? So both actinic cell and a mask, both are malignant in nature. So MASC, it showed less or no basophilic granularity. Unlike the actinic cell carcinoma, which showed that zymogen granularity, this particular tumor does not show any basophilic granularity, and also it expresses immunohistochemistry markers. We know actinic cell carcinoma DOG1, directly observed gastrointestinal marker, was positive for actinic cell carcinoma, whereas MASC, it lacked the GO1 expression, and also it strongly expressed other markers like S100 and mamma globin. And of course, the gene fusion, that is ETV6 NTRK3, which was specific for secretory carcinoma. And the gross features would be, it showed a firm rubbery mass, just like breast carcinoma. It showed numerous cystic or yellowish fluidy spaces in between, and also showed perineural invasion and the lymphovascular invasion and the necrosis were uncommon in this. So histologically, as I said, a gross well-circumscribed lesion with fibrous septa separating it into microcystic, tubular, or solid structures. Depending upon the areas, the different patterns showed different, in different regions showed different patterns, and abundant bubbly secretions were seen on the ductal spaces or tubular spaces, which is musicarvin positive and PAS positive. And a fibrosclerotic stroma was also present. And the individual tumor cells were basically low-grade vesicular round oval nuclei, and it showed pale eosinophilic cytoplasm and vacuolated or foamy appearance. So the MASC basically had a zymogen granule poor appearance, unlike actinic cell carcinoma. Okay, so MASC with high-grade transformation and low-grade transformation both were seen, and in high-grade transformation, commonly perineural invasion was noted, and comedo type of necrosis was also seen. So these are some of the histological pictures where you can see numerous microcystic spaces filled with, this is PAS stain showing PAS positive material within the ductal spaces, when you have fibrous septa separating the tumor cells. This is kind of numerous ductal spaces or cystic spaces with the material in between. And the tumor cells, you can see these are a zymogen granule poor type of cell where less of eosinophilic cytoplasm and more of vacuolated or clear cytoplasm is seen. Okay. And IHC point of view, as I said, it showed positivity for S100, mamma globin, the normal cytokeratin 7, 8, 18, and 19 positivity, whereas DOG1 was negative. Okay. And the particular marker, that is GCDFP, that is gross cystic disease fluid protein 15. Okay, that was particularly seen in MASC positivity, where it was common in breast C as well. SOX10 and GATA3 positivity was also seen. And the basal cell markers like P63, calponin 6CK14 all were virtually negative. So these are the IHC markers, the individual tumor cells taking up those markers. So this is that fluorescent in situ hybridization, where you can see that ETV6 NTRK3 fusion, where as red and yellow or red and green type of gene fusion can be seen. This is a view under DAPI of fluorescent microscope. Yeah. So differential diagnosis would be actinic cell carcinoma, intraductal carcinoma, or low-grade mucoepidermal carcinoma even. Okay. So see how similarity it looks like with that of actinic cell carcinoma, or even adenoid cystic carcinoma, or polymorphous low-grade carcinoma, and mucoepidermoid carcinoma, low-grade, where it shows numerous of cystic spaces. So these are the basic differences. In a nutshell, you can see both in parotid as well as minor salivary gland, female predominance in actinic, whereas male predominance in secretory carcinoma, cyanogen granule poor, less. Then you have this mammaglobin positivity, DOG1 negativity, then EPV6 NTRK3 positivity. Okay, so that's about secretory carcinoma. So the treatment of choice would be surgical resection, basically, followed by radiation therapy as well as systemic chemotherapy. Then coming to Cribriform Adenocarcinoma, which was another variant, which is now grouped under the polymorphous adenocarcinoma group. And usually it is located in the posterior oral tongue and base of the tongue. Hence it was called as CAT, or Cribriform Adenocarcinoma of tongue. So now it is a variant of polymorphous adenocarcinoma. And it is commonly now known as Cribriform Adenocarcinoma of minor salivary gland origin. It is also similar to PLGA, whereas the tumors are unencapsulated, white to tan to gray in color, hard in consistency, and they are approximately 1 centimeter larger than PLGA on an average. So histologically, it exhibits pseudoepitheliomatous hyperplasia and lymphovascular invasion, whereas perivascular invasion is, perineural invasion is not much prominent, whereas lymphovascular invasion is common. Then it also showed solid cribriform microcystic and glomeruloid type of patterns in various regions, and its nuclei was more or less similar to the papillary carcinoma of thyroid nuclei. There is orphananiide appearance, the optically clear and vesicular nucleus with a ground glass appearance was seen. And yes, as I said, it is not as neurotropic as in polymorphous low grade, whereas it showed much of lymphatic invasion. Nodal metastasis had an identical appearance to tumors, and it was misdiagnosed as papillary carcinoma of thyroid in neck masses. So this is how the Cribriform adenocarcinoma looks. This is the typical nuclei that is present, which is resembling to papillary carcinoma of thyroid, that is orphananiide type of pattern. Then you have the polymorphous Indian file, typical Indian file pattern that also can be seen here. So clinically, both equal male to female predominance and local recurrence rate of 10 to 30%, and regional metastasis was common. And as I said, the DD would be polymorphous low-grade adenocarcinoma, where you showed the typical Indian file, tubule vesicle formation, solid cribriform papillary structures, differences in that of the nuclei, which was less similar to papillary carcinoma of thyroid. So these are the basic differences between PLGA and CSG. And the PLGA, the molecular alterations just see into consideration. That is, PLGA, you have a PRKD1 point mutation, whereas in CSG, you have PRKD1 to 3 translocation with ARID1A and DDX3 partner gene mutations. Okay, and perineural invasion common in PLGA, whereas CSG, you have more of lymphatic invasion. So another DD would be adenoid cystic carcinoma. You know that cribriform and cribriform type of pattern can be seen, whereas adenoid cystic carcinoma expressed more of a blue mineral type of P63 staining. This one showed more of diffuse staining with P63. And c-KIT and NYB markers were positive for adenoid cystic carcinoma, overexpressed, but not much expressed in cribriform adenocarcinoma. Okay, so that is about some of the major carcinomas that were added into it, and some of the terminologies of low grade was removed. And coming to sclerosing polycystic adenosis or adenoma, which was another new epithelial lesion which was added by Smith in 1996, which was described as a non-neoplastic sclerosing and inflammatory process. Okay, it harbors intraductal epithelial dysplastic proliferations ranging from mild dysplastic features to severe dysplasia or carcinoma in situ. So basically, during our postgraduate period, I have seen only one case of sclerosing polycystic adenosis where there was a firm or rubbery mass which was well circumscribed, surrounded by normal salivary gland tissue. But the typically pale and glistening with multiple tiny visible cystic spaces were seen. But it was a well circumscribed benign mass and could be easily differentiated from that of an inflammatory lesion because inflammatory component was minimal and also an invasion component was also minimal or no. So histological features, it showed a well circumscribed mass with the lobular architecture and multiple dilated ducts, and the ductal cells showed vacuolated foamy or apocrine mucus appearance, and the hallmark was large SNR cells with numerous PAS positive cytoplasmic granules were noted. And it showed vacuolated foamy cells with sebaceous-like appearance and solid microcystic or cribriform structures were seen. Nuclear pleomorphism was also noted with mild to severe nature, sometimes amounting to a low-grade ductal carcinoma in situ, as was the case where only very less of nuclear pleomorphism was noted. So this is how numerous cystic spaces were seen with some of the PAS positive material within the cystic spaces. An inflammatory component was minimal and a fibrous well encapsulated lesion was noted with no or less nuclear pleomorphism or atypia was less. So ductal SNR cells were positive for cytokeratin and variably positive for epithelial membrane antigen S100 positivity, HER2 new negativity. And SNR cells with coarse eosinophilic cytoplasm were positive for GCDFP15. And ducts were filled with hyperplastic and dysplastic epithelium is surrounded by intact myoepithelial layer, which was positive for SMA, P63, and calponin. So this is a staining of the abluminal cells with myoepithelial markers. So differentiating it from pleomorphic adenoma and chronic sclerosing sialadenitis, you have this characteristic lobular growth pattern where large parent cells like cells of SNR cells were seen in SPA, but not in pleomorphic adenoma. And SPA lacked that much of myoepithelial component and abundant that chondromyxoid stroma, which is typically of fibromyxoid stroma, which is present in pleomorphic adenoma, which was absent in this one. And also that unlike chronic sclerosing sialadenitis, you have that inflammatory component was less, and also PAS positive cymogen-like cytoplasmic granules were seen in this one, that is SPA. Okay, another carcinoma which was added was intraductal carcinoma. So intraductal carcinoma, both it could be similar because both the tumors share propensity to myoepithelial layer with occasional high-grade dysplasia and S100 immune expression. But the key histological features of SPA, however, include proliferation of SNR cells from that of large eosinophilic cytoplasmic cymogen granules. So ductal cells showed variable morphology of foamy, vacuolated apocrine or mucus type of cells were seen, which was absent in intraductal carcinoma. And with that of ethnic cell carcinoma, low grade, how could you differentiate? PAS positive material obviously was present for ethnic cell carcinoma as well, but ethnic cell carcinoma never had the varied architecture of that lobular architecture was not there. And also dogma expressive was absent in SPA. Mucus cells are largely absent from SPA. Hence, it could be differentiated from low-grade MEC. And furthermore, myoepithelial layer surrounding the cyst, duct, and SNI was not seen in ethnic cell carcinoma or mucoepidermoid carcinoma. So these are the basic clinical features: 40 years, 22 to male to female ratio of 2:3, parotid submandibular glands, and management was surgical enucleation with complete and conservative local surgical resection. The another variant of myoepithelioma which was added was mucinous or secretory myoepithelioma. And this basically consists of mainly myoepithelial cells, which were spindle, plasmacytoid, or epithelioid, or any kind of other morphology. And myoepithelial neoplasms are uncommon, accounting for 1.5%. So it's very difficult in diagnosing myoepithelial tumors because almost similarity to other tumors as well. So this is how a sheets of myoepithelial cell tumor, but cellular myoepithelioma kind of appearance. So histologically, you have this grayish blue cytoplasm tumors showing intracellular mucin, pleomorphism, peperichromatin, multinodular focally invasive tumor cells, and you have moderate to nuclear pleomorphism and plasmacytoid type of configuration and areas, and focal areas with extracellular mucin material could also be present. So would be positive for SMA, 100, GFAP, C, calpone, and smooth muscle myosin, P63 or CAM, cell adhesion molecule 5.2. So malignant tumors daily positively for calpone, cytokeratin cocktail, S100 and CK7. So this is the histological pictures of mucinous variant of myoepithelioma, where you have those typical mucus cells also seen in between. Mucus secretions also can be seen. So one should use the same histological criteria for this tumor to evaluate for malignancy as with any myoepithelioma, like circumscription, encapsulation, destructive peripheral growth, increased proliferative rates, neural vascular invasion, tumor necrosis, and depending upon the degree of nuclear pleomorphism. So differentiating it from mucoepidermoid carcinoma, colloid carcinoma, salivary duct carcinoma with signet ring type of cells also should be ruled out. Okay, so MEC had mucin positive cells along with other cells like squamous process of squamous differentiation and epidermoid cells, intermediate cells always seen. And it would be negative for myoepithelial specific markers. And colloidal carcinoma, unlike mucinous myoepithelioma, will have abundant pools of extracellular mucin material, not much in myoepithelioma mucinous variant. And salivary duct carcinoma with signet ring cells will have a foci of more or less typical salivary duct carcinoma, and comedo type of necrosis can be seen, black staining with myospecific markers. So other lesions included intercalated ductal hyperplasia, where there was a proliferation of intercalated duct caliber tubules, and it represents actually a precursor lesion to that of any intraductal carcinoma. So excessive proliferation, just like even myoepithelial carcinoma, we can confuse it. So parotid gland lesions are common, and well demarcated or encapsulated nodular lesions are designated as IDA, while the term IDH is retained for unencapsulated expansile proliferations that retain the lobular architecture. So intercalated ductal adenoma and hyperplasia, how it could be differentiated? One is capsulated, one is unencapsulated or expansile. And then nodular oncocytic hyperplasia and lymphoepithelial lesions that were also characteristically added. It was almost exclusively a lesion of the parotid occurring in 5th to 6th decade. Multiple unencapsulated solid to tubulotrabecular patterned nodules of oncocytes were seen. Clear cell oncocytosis with clear cell change. So clear cell oncocytoma, like that of clear cell oncocytoma, it could resemble. Whereas the latter, the clear cell oncocytosis, the latter being more frequently bilateral and prone for recurrence. So in contrast to oncocytoma, there is no dominant encapsulated lesion. The clear cell predominance may mimic the appearance of metastatic renal cell carcinoma, though the nodular oncocytic hyperplasia does not show the hemorrhage or vascularity that is seen in renal cell carcinoma. So DD has to be oncocytoma or clear cell renal carcinoma, which has to be removed. So typical clear cell appearance can be seen within the tumor cells as nodular growth patterns are also observed. And lymphoepithelial lesions are just like any other lymphoepithelial sialadenitis, like in Sjogren's syndrome or Michel's syndrome or whatever, where you can see epimyoepithelial islands or lymphoepithelial proliferations above, surrounding the islands. So similar to that, some of the lymphoepithelial lesions both showed cystic and non-cystic versions. So they characterized by metablastic cells infiltrated by lymphocytes, and lymphoid component effaces the surrounding SNI and contains germinal centers. And when cystic, the lymphoepithelial lesions may overlap with the cystic lymphoid hyperplasia seen in immunosuppressed patients. And when malignant transformation occurs, it is most frequently the lymphoid component, resulting in marked lymphoma. So soft tissue lesions, in addition to hemangioma, lipoma and nodular fasciitis were added. So the last part, the key molecular alterations which were added to the recent WHO 2017 classification were this. So you can just take a look about it. because the gene fusions and gene mutations which have been added for each of the tumor, like pleomorphic adenoma, MEC, adenoid cystic carcinoma, secretory carcinoma, and hyalinizing glial cell carcinoma has been shown in this table. So I think that will be helpful for the PG students during their preparation. So to end the seminar, I'd like to just emphasize on some of the facts, like secretory carcinoma, which was added. Then you have the SPA, which was added as new entity. Then the low-grade terminology was removed. Then you have that Cribriform Adenocarcinoma minus Salivary Gland origin, which was added into the polymorphous variant. And some of the other epithelial lesions already discussed, like the nodular oncocytic hyperplasia, intercalated ductal hyperplasia, all those lesions were added. So these are some of the changes that have been brought into the new latest WHO classification. So hoping that this would be useful for PGs as well as interested UGs who find it very difficulty in diagnosing some of the lesions. So WHO has even more complicated by adding some of the new lesions and modifying some of the older lesions. So hoping that the seminar was useful. Thank you. So recent updates always serve as an add-on to the existing knowledge on salivary gland pathology. So salivary gland, where you have a wide spectrum of tumors, adding some more tumors to the list is always diagnostically challenging. And as always, the morphological overlap of these different entities have made it even more difficult in diagnosing. So just be in touch with the new tumors also. So hoping that this was useful. Thanking you. Thank you. So these were my references. By Alan Skelova was the article where he has described in great depth about these tumors. So those who are interested can always go with these references where you can read more on the same tumors which already discussed. So thanking you once again. Have a nice day.